Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services, so I humbly urge you to sit back and spare me part of your very precious time to share with you some very precious and useful tips which may prove very handy in your line of duty. So I welcome you to part 79 of our Pharmacotherapy MCQ series, which majors in basic oncology. Question number 1 reads, in which of the malignancies listed below can rituximab be used as monotherapy or in combination with chemotherapy? Is it in the B-cell type of non-Hodgkin's lymphoma, or is it in the T-cell type of non-Hodgkin's lymphoma, or is it in the case of plasmacytoma or Hodgkin's disease? I'll give you 10 seconds to choose the correct answer. So A is the correct answer. It is in the B-cell type of non-Hodgkin's lymphoma. Now, B-cell lymphomas make up the majority of lymphomas. I would just like to add that non-Hodgkin's lymphoma is a group of proliferative malignancies that have differing patterns of behavior and response to treatment. Let's move to the next question, please. And it reads, Mrs. PLN, a 64-year-old female patient, presents to your hemato-oncology clinic with suspected leukemia. Some of her pertinent labs on admission to your hospital shortly include a white blood cell count of 722, HB of 8.1, hematocrit of 247, platelet count of 333, the sodium levels are 142 milliequivalents per liter, potassium levels are 4.6, CO2 is 27, the BUN is 26, creatinine is 1.34, phosphate levels are 5.8, the uric acid levels are 12.9, and LDH is 1933, and the calcium levels are 9.6. And upon admission, it was established that Madam PLN has experienced weight loss over the past half a year, 6 months to be specific, and she complained of occasional fevers at night. And you established that she doesn't experience fatigue, neither does she experience dyspnea on exertion. So my question to you is, which of the problems listed below should be addressed before having a diagnosis and initiating chemotherapy in the case of Mrs. PLN? Should it be weight loss, tumor lysis syndrome, hyperphosphatemia, or anemia? I'll give you 10 seconds to choose the correct answer. Personally, I would address the tumor lysis syndrome. Now, Madam PLN is undergoing tumor lysis syndrome without the administration of any chemotherapy so far, and this is indicative of high uric acid, elevated phosphate, and even LDH. Now, her potassium is within normal limits, but it needs to be monitored closely since this value may rise slightly after initiation of treatment. And then anemia could be addressed with transfusion. However, Mrs. PLN isn't overtly symptomatic. There are no issues of fatigue and so on and so forth. And usually transfusion is done below HB levels of 8 grams per deciliter. So I wouldn't be too quick to infuse her or to transfuse, sorry, at this stage. I would just like to add that weight loss will improve once the leukemia is treated or addressed. And because of all those many words, answers A, which is weight loss, answer C, which is hyperphosphatemia, and answer D, which is anemia, are all wrong. And I would focus on tumor lysis syndrome. Let's move to the next question, please. And it reads, which of the following factors listed below are risk factors for chemotherapy-induced nausea and vomiting? Is it minimal or no alcohol consumption? Is it patients below the age of 50 years? Or is it female gender? Or are all the above options A, B, and C applicable? I'll give you 10 seconds to choose the correct answer. So all of them are applicable. All the above are classic risk factors for chemotherapy-induced nausea and vomiting. It is well known that minimal alcohol intake substantially in young women increases the risk. Now, if a patient has chronic alcohol consumption that is equal to or more than 100 grams per day for several days, the risk of vomiting diminishes in such cases. Now, other risk factors for CINV, chemotherapy-induced nausea and vomiting, include a history of motion sickness, pregnancy-related emesis, prior chemotherapy-related emesis, and even high anxiety levels. Let's move to the next slide, please. And the question reads, in which of the following clinical scenarios would it be most difficult to control CINV? Would it be in the case of a patient receiving his 4th cycle of carboplatin co-administered with etoposide? Or would it be a patient receiving high-dose chemotherapy involving camustin, etoposide, cytarabine, and melphalan, which is abbreviated as BEAM, before HSCT, hematopoietic stem cell transplant? Or would it be a patient receiving his 3rd cycle of 5-fluorouracil, leucovorin, and oxaliplatin, what we abbreviate as FOLFOX? Or would it be a patient receiving his 1st cycle of carboplatin and etoposide? I'll give you 10 seconds to choose the correct answer. So B is the correct answer. It would be the patient receiving high-dose chemotherapy involving camustin, etoposide, cytarabine, and melphalan, what we call BEAM, before hematopoietic stem cell transplant, and I'll explain why. Now, most preparative regimens for HSCT are highly emetogenic, and they can produce profound acute and delayed nausea and vomiting. And I would just like to add that carboplatin and Folfox regimens are both considered moderately emetogenic, and that makes C wrong, A wrong, and even D wrong, and leaves us with B as the most appropriate choice in this particular question. Let's move to the next question, please. And it reads, Mrs. WPW, a 79-year-old female who was recently diagnosed with breast cancer, is scheduled to receive doxorubicin and cyclophosphamide. Due to her past medical history of type 2 diabetes mellitus, she has significant peripheral neuropathy. She is Polish by nationality and doesn't speak or understand English well. So my question to you is, which of the following is a risk factor for extravasation in Mrs. WPW's case? Is it age, doxorubicin, neuropathy, and language barrier? Or is it age, cyclophosphamide, neuropathy, and language barrier? Or is it gender, cyclophosphamide, breast cancer, and language barrier? Or is it gender, doxorubicin, breast cancer, and neuropathy? I'll give you 10 seconds to choose the correct answer. In this case, A is the correct answer, as multiple factors can increase the risk of extravasation, from peripheral veins in the case of Madam WPW, such as small and or fragile veins, obesity that obscures veins from view, multiple previous venipunctures if they happened, disseminated skin diseases such as eczema or psoriasis, and even patient movement or prior treatment with the low pH and caustic drugs, and even limited vein availability, especially in cases where there are lymph node dissections or where there is lymphedema, and even when there is limb removal or other similar conditions. And sensory deficits such as post-cerebrovascular accident or paralysis can also pose a challenge, and even sedation and somnolence, and even impaired cognition and altered mental status. All those can increase risk of extravasation in such patients. Now, just like to add that older age increases the risk of having extravasations, as older patients have small and fragile veins in most cases, and we know that Madam WPW has peripheral neuropathy, and that may prevent her from realizing when the drug is being extravasated. That would pose a risk. And language barrier may impair optimal communication and delay appropriate care for such a patient. I would just like to add that doxorubicin is a non-vesicant, and therefore WPW may be at an increased risk of toxicity from extravasation of this agent. And then gender and type of cancer have no impact on the risk of extravasation. Then I would just like to add that endoxan, cyclophosphamide, isn't considered a vesicant, although it may be an irritant. So all that makes me biased towards A. I would just like to add that risk factors for extravasation include, and I'll repeat, age, sensory deficit, language barrier, and the administration of vesicant chemotherapy agents such as the alkylating agents, the anthracyclines, the vinca alkaloids, and even tangzins. Then, although published vesicant extravasation incidence rates range from 0.01% to 6.5%, the true incidence rate is closer to the lower end of the reported ranges. So all those many words make answer A the most appropriate in this particular question. Let's move to the next question, please. And it reads, Mr. T.W.P., a 65-year-old male patient with a known history of multiple myeloma, had only partial response after autologous hematopoietic stem cell transplant 90 days ago, 3 months ago. Then difficulty swallowing and significant ulceration of his mouth and throat complicated his previous autologous hematopoietic stem cell transplants. The oncology team at your hospital has decided to have him receive the second autologous hematopoietic stem cell transplant with melphalan at a dose of 140 milligrams per meter squared and total body irradiation. So my question to you is, which of the options listed below would be the best with regards to the planned second hematopoietic stem cell transplant to minimize or to reduce the risk of previous complications? Would it be start methotrexate for graft versus host disease prophylaxis on day 21 plus, or double the dose of filgrastim, or administer polypharmain pre and post conditioning regimen, or reduce the melphalan dose by 50%. I'll give you 10 seconds to choose the correct answer. So polypharmain pre and post conditioning regimen would be the best option here. Now polypharmain is a recombinant human keratinocyte growth factor that stimulates and protects epithelial cells, to be specific, and it has shown an absolute risk reduction of 35% roughly in severe mucositis in patients undergoing autologous hematopoietic stem cell transplant with irradiation as part of the conditioning regimen. And polypharmain reduces the duration of mucositis from 9 to 3 days according to studies. And I'd just like to add that reduced doses of melphalan may reduce the risk of mucositis, but it may adversely impact the efficacy of the hematopoietic stem cell transplant. Therefore, it may not be the best option in my opinion. Then filgrastim may primarily help reduce the risk of neutropenia and febrile neutropenia, but not mucositis, so that would not be the best option. And I would like to add that since Mr. TWP is receiving autologous hematopoietic stem cell transplant, he isn't at risk of graft versus host disease. So all those many words make me biased towards choice C. Let's move to the next question, please. And it reads, which of the monoclonal antibodies listed below is conjugated with a toxin? Is it ipilimumab, marketed as Yervoy, or is it ofatumumab, marketed as Azera, or is it brentuximab, marketed as Adcetris, or is it alemtuzumab, marketed as Kempath? I'll give you 10 seconds to choose the correct answer. So brentuximab or adcetris is the correct answer. Now, brentuximab is combined with vedotin or with monomethyl uristatin E, which is a microtubule disrupting agent causing cell cycle arrest and can also lead to apoptosis. Now, brentuximab is a monoclonal antibody designed to bind with what we call the CD30 positive cells. And the combination brentuximab vedotin is an antibody drug conjugate, what is abbreviated as ADC. Just as by the way, let's move to the next question, please. The next question reads, which of the statements listed below is true? Is it olanzapine, palonosetron plus dexamethasone, or etipitant co-formulated palonosetron plus dexamethasone are both alternative regimens which can be used for prevention of acute and delayed nausea and vomiting associated with highly emetogenic chemotherapy? Or is it true that granisetron transdermal patches, which are marketed as Sancuso, patch is administered 2 hours before chemotherapy to prevent acute nausea and vomiting? Or is it true that the Sancuso patch should be worn for 3 days after chemotherapy? Or is it true that dexamethasone, when used concomitantly with aprepitant and ondansetron, should be increased due to concerns for decreased efficacy as a result of a potential CYP3A4 interaction? I'll give you 10 seconds to choose the correct answer. So it is true that olanzapine, palonosetron plus dexamethasone or the etipitant co-formulated with palonosetron plus dexamethasone are both alternative regimens which can be used for the prevention of acute and delayed nausea and vomiting associated with highly emetogenic chemotherapy. I would just like to start by saying that Sancuso should be applied to the upper outer arm at a minimum of 24 hours and a maximum of 48 hours prior to chemotherapy. It's written in literature in the insert. Now, the patch releases 3.1 milligrams of granisetron per 24 hours for up to 7 days, and therefore it may be worn for up to 1 week. And I would like to add that aprepitant is a moderate CYP3A4 inhibitor which inhibits the metabolism of dexamethasone. Thus, the dose of dexamethasone in the recommended 3-drug regimen, that is of aprepitant, dexamethasone and ondansetron, should be reduced to 12 milligrams on day 1 and 8 milligrams from day 2 to day 4. Please note that. I would like to add that olanzapine, palonosetron plus dexamethasone or etipitant co-formulated palonosetron plus dexamethasone can be considered for the prevention of nausea and vomiting with highly emetogenic chemotherapy. Proves very useful in such clinical scenarios. Let's move to the next question, please. And it reads, Mr. TMC, a 56-year-old man suffering from colorectal cancer, is receiving cetuximab. So my question to you is, for which of the side effects listed below should your oncology clinical pharmacist counsel Mr. TMC? Should it be bleeding, hypermagnesemia, arterial thrombosis, or QT interval prolongation? I'll give you 10 seconds to choose the correct answer. Hypomagnesemia it is. Now, hypomagnesemia is a relatively common side effect associated with epidermal growth factor receptor inhibitors, what we call the EGFR inhibitors, which include panitumumab and cetuximab. So that makes it the right answer in this particular case. Now, although the mechanism responsible for electrolyte imbalance isn't well understood, increased EGFR expression in the ascending loop of Henle may lead to renal tubular damage and interfere with magnesium absorption. I would like to add that electrolytes should be monitored routinely and for 8 weeks after the completion of an anti-EGFR therapy, since magnesium levels typically return to normal after approximately 4 to 8 weeks after discontinuation of these agents. Now, I would like to add that QTC prolongation, arterial thrombosis, and bleeding, in my opinion, aren't commonly associated with cetuximab. And I would like to comment that hypomagnesemia, secondary to anti-EGFR therapy, can lead to cardiovascular, neuromuscular, and even behavioral symptoms, and can also be associated with hypocalcemia. So it's very dangerous indeed. You have to pay attention to it. And this type of hypocalcemia is due to hypomagnesemia induced parathyroid hormone resistance and can only be corrected by replacing the magnesium that is lost. Let's move to the next question, please. And it reads, what is the mechanism by which Gliomycin causes pulmonary disease accompanied by skin hyperpigmentation? Is it true that Gliomycin isn't toxic to the skin or the lungs? Or is it true that Gliomycin is metabolized by Gliomycin hydrolase, which is present in low levels in the lungs and skin? Or is it true that the vasculature is unable to filter Gliomycin as it travels through the lungs and the skin? Or is it D, Gliomycin mimics asbestos, which is toxic to the mesothelial and epithelial cells? I'll give you 10 seconds to choose the correct answer. So B is the correct answer here. Gliomycin is metabolized by Gliomycin hydrolase, which is present in low quantities in both the lungs and the skin. Now, Gliomycin undergoes detoxification through metabolism under the influence of that enzyme there, Gliomycin hydrolase, and theoretically, if the skin and lung enzyme concentrations are absent or low, those tissues may be more susceptible to toxicities, and that is why it happens. Let's move to the next question, please. And it reads, your oncology clinical team is treating Mrs. JTS, a 56-year-old female patient weighing 50 kilos who has non-small cell lung cancer, who has recently been initiated on pembrolizumab. 28 days after initiating this regimen, Mrs. JTS begins complaining of extreme fatigue and weakness. She also complains of weight gain, hair loss, and constipation. Her TSH is 15 million units per liter, and her T4 is 5.1 mics per deciliter. she is otherwise stable. Now, as the oncology clinical pharmacist in this team, which of the following recommendations would you consider appropriate as a form of intervention in the case of Mrs. JTS? Would you advise the team to continue pembrolizumab at a reduced dose and to monitor both TSH and T4 every 6 weeks? Or would you recommend they hold pembrolizumab until JTS's symptoms return to baseline and then start prednisone 50 milligrams per day and then recheck TSH and T4 in 6 weeks' time? Or would you advise the team to hold pembrolizumab until Mrs. JTS's symptoms return to baseline and then start levothyroxine and recheck both TSH and T4 levels in 6 weeks? Or would you recommend they hold pembrolizumab until Mrs. JTS's symptoms return to baseline and recommend they start levothyroxine and prednisone 50 milligrams per day and recheck both TSH and T4 levels in 6 weeks? I'll give you 10 seconds to choose the correct answer. So C is the correct answer here. Now, according to what we call the common terminology criteria for adverse events, which is abbreviated as CTCAE, primary hypothyroidism is graded as follows. Now, in grade 1, the TSH is below 10 million units per liter and the patients are basically asymptomatic. Now, in grade 2, they have moderate symptoms. Patients are able to perform activities of daily living and TSH is persistently above 10 million units per liter. Now, in grades 3 and 4, there are severe symptoms which are medically significant. There are life-threatening consequences of such symptoms, and such patients are usually unable to perform activities of daily living. Now, our patient here is considered to have grade 2 hypothyroidism, for which the treatment is to hold the immune checkpoint inhibitor, which we are using in this therapy, until the symptoms resolve to baseline. I would like to add that thyroid hormone replacement should be given to symptomatic patients with any degree of TSH elevation, or to asymptomatic patients with TSH levels that remain above the 10 million international units per liter, and that should be measured 4 weeks apart, if I remember what I read in literature well. Now, based on this patient's symptoms, she should be monitored, or she should be started rather, on levothyroxine, and her TSH and T4 levels should be routinely monitored. Now, I would like to add that steroids aren't part of the ASCO recommendations for management of immune therapy related primary hypothyroidism. Now, unlike GI or skin toxicities, primary hypothyroidism is an immune-mediated adverse effect which isn't managed with steroids. So don't use any steroids at all. That rules out answer D, and it also knocks out answer B automatically. Let's move to the next slide, please. So that marked the end of this video. Now, if this video helped you in any way, I would like to urge you to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the best is yet to come. Thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your kind collaboration, and I look forward to interacting with you in subsequent MCQ series. Thank you very much.